Welcome to Everything Medical. This channel is all about breaking complex concepts into simpler, digestible one. So if you're coming across new to this channel, endeavor to subscribe and hit to the subscribe button to get notification when we upload videos. Now, today's video is all about the anatomy of the humerus. The humerus is the long bone of the arm. It is the strongest and the longest bone of the upper limb. So it has three parts. The proximal end, which is the upper shaft, upper half, and it has the shaft, which is the long portion, and the distal end, which is the lower half. Let's discuss the proximal end, which is the upper half. The upper half, the proximal end, has the following features. It has the head, it has the anatomical neck, it has the greater tubercle, the lesser tubercle, the intertubercular sulcus or the vertical groove of the humerus, which can be called the basipital groove, and it has the surgical neck. Now, the head of the humerus is smooth and rounded. It forms less than a half of a sphere. Get it forms less than half of a sphere, which is where it is directed medially, backward and upward. It is directed medially. As you can see it, this is how it is being placed. It is directed what? Medially, backward and upward. Get so that is how it is being done, and it provides an articulation, or it articulates with the glenoid cavity of the scapula to form the shoulder joint, which can be called the glenohumeral joint. Get this head of the humerus is covered by a hyaline articular cartilage, which is thicker on the center, but it is become peripheral on the outer aspect. Like it becomes thinner on the peripheral aspects, I mean to say. As you can see, this is the anatomical neck of the humerus. The anatomical neck of the humerus is the constriction of the margin of the rounded head of the humerus. This is the anatomical neck of the humerus. It is the constriction of the rounded head, or the constriction of the margin of the rounded head of the humerus. And this anatomical neck provides site of attachment of the capsular ligament of the shoulder joint, except superiorly, where it creates a passageway for the tendon of the long head of the bicep brachii. Okay, this is the greater tubercle. The greater tubercle is the most lateral projected part of the proximal end of the humerus. It is the most lateral. As you can see, it is lateral. It is away from the median plane of the body. So it is the most lateral projected part of the proximal end of the humerus. Okay. On its posterior superior aspect, which is here, this is the posterior superior aspect. It is posterior and superior, but because this is the posterior surface of the humerus now, you get this is the posterior surface of the humerus. So on its posterior superior, which is upward aspect, it bears a flattened facet-like impression, which is found on the upper, the middle, and the lower. This impression is for the attachment of the muscles of the musculotendinous cuff muscles, which is the rotator cuff muscles. The upper impression is for supraspinatus, the middle is for infraspinatus, while the lower is for teres minor muscle. Okay, that is all about it. It's all about the greater tubercle. Now, the lesser tubercle is a bony extension that is found below the anatomical neck of the humerus. You get it provides sites of attachment of the subscapularis muscle, which is one of those muscles that forms the musculotendinous cuff muscle or the rotator cuff muscles. Okay. Recall that on the anatomical neck of the humerus, you get the anatomical neck of the humerus is vital. Bear it in mind. It is vital, although it is not the neck of the humerus that is prone to fracture. It is the surgical neck that is prone to fracture. Now, in between the greater and the lesser tubercle, here is the vertical groove known as the intertubercular sulcus or the basipital groove of the humerus. It's found between the greater and the lesser tubercle. This groove lodges the long head of the bicep brachii. You get the tendon of the long head of the bicep brachii covered by the synovial sheath, and it lodges an important blood vessel. You get those are the content of the basipital groove of the humerus. Yes. Now, the lateral lip of the basipital groove of the humerus give attachment of the pectoralis major muscle. The floor lodges the latissimus dorsi, while the medial lip lodges the teres major muscle. So the mnemonic to remember these muscles is the lady in between the two major. Lady in between the two major. The L is for latissimus dorsi, while the two majors is for pectoralis major muscle and teres major muscles. Now, the surgical neck of the humerus, which is the most important feature on the proximal end of the humerus. The surgical neck of the humerus is the one that is prone to fracture. Yet it is the constriction of the upper end or the constriction of the upper half of the shaft of the humerus, yet, which is below the lesser and the greater tubercle. There are vessels that are related to this surgical neck, which include the axillary nerve and the anterior and posterior humeral vessel. That which means injury to the surgical neck or fracture to the surgical neck will cause lesion or damage to those vessels. You could see it in your MCQ. You could see this question in your MCQ. What are those structures that got lesion when there is a fracture to the surgical neck of the humerus? It is the axillary nerve and anterior and posterior humeral vessel. Okay, that is all about the proximal end of the humerus. Okay, now let's delve into the shaft. The shaft of the humerus is the long portion of the humerus. As you can see, it is the long portion of the humerus. The long portion of the humerus. From here, it extends from the upper proximal end upward to the lower distal end or the lower half of the humerus. You get. Now, it is cylindrical on its upper half. It is cylindrical on its upper half, while it is flattened anterior inferiorly on its lower half. It is flattened anterior inferiorly on its lower half. As you can see, it is flat. It is flat on its lower half. Get anterior inferiorly. Get. So that is all about the shaft. The shaft of the humerus is divided, or it has borders and surfaces. It has three borders and three surfaces. It has the lateral border, the anterior border, and the medial border. This is the medial border, the anterior border, and the lateral border. The anterior border of the humerus extends from the lateral lip of the intertubercular sulcus down to the anterior margin of the deltoid tuberosity. That is all about the anterior border. The medial border extends from the medial lip of the intertubercular sulcus down to the medial epicondyle of the humerus. And the medial border has a sharp edge, which is what we call the medial supracondylar groove. This medial supracondylar groove provides site of attachment of the medial intermuscular septum of the arm. Okay, the lateral border. Here is the lateral border. The lateral border on its upper end is indistinct. It is poorly defined. As you can see it here. The upper end of the lateral border is not distinct, yet it's poorly defined. It is the lower end that has a sharp edge, which is called the lateral supracondylar ridge. Now, this lateral supracondylar ridge provides site of attachment of the lateral intermuscular septum of the arm. Now, let's delve into the surface. we have the anterior lateral surface, the anterior medial surface, and the posterior surface of the humerus. Okay, this is it here. The anterolateral surface is found between the lateral and the anterior border. The anteromedial surface is found between the anterior and the medial border. Now, the posterior surface is found between the lateral and the medial borders. That is how it is being formed. It is easy to remember. Very, very easy to remember. Okay. Now, recall that on this posterior surface, on the upper half of the shaft of the humerus, lies the spiral groove of the humerus, which can be called the oblique groove because it runs obliquely. It runs obliquely like this. It is not vertical, nor horizontal, nor transverse. It runs obliquely. And it can be called the radial groove because it accommodates the radial nerve, which originates from the posterior cord of the brachial plexus. So it enters the posterior compartment of the arm by passing between the long head of tricep brachii that attaches on this upper half of the shaft and the medial head of the tricep brachii. So it enters the oblique groove. That is why it's called the radial groove. Recall that in the radial groove, the profundal brachial artery accompanies the radial nerve. Now, injury to the shaft of the humerus will cause lesion, or fracture to the shaft of the humerus will cause lesion to the structures in the spiral groove because the spiral groove will be affected, thereby causing damage to those structures, which include the radial nerve and the profundal brachial vessel or the profundal brachial artery. That is how it goes. Okay, let's delve into the distal end of the humerus. This is the distal end of the humerus. As you can see, the distal end is from the both shaft. The both ridge, the medial supracondylar ridge and the lateral supracondylar ridge. Now, the medial supracondylar ridge of the humerus is the sharp edge that is found on the distal end of the humerus. It provides sort of attachment of the medial intermuscular septum of the arm. This here is the medial epicondyle. The medial epicondyle is a bony medial projection or is a medial bony projection that is found on the medial side of the distal end of the humerus. It is a vital bony projection on the medial side of the distal end of the humerus. The anterior surface of the medial epicondyle, this region here, look at this region that is marked. This region here provides site of attachment of the common flexor origin. The common flexor origin is the common origin of the superficial flexors of the forearm. Then the posterior surface of the medial epicondyle of the humerus gives a passage for the ulnar nerve. It is a site where ulnar nerve can be entrapped, the site of ulnar nerve entrapment. In case if there is any cut on the pinky finger, the ulnar nerve can be entrapped at the posterior surface of the medial epicondyle of the humerus so that the surgery can be conducted. So it is for anesthetic purpose, anesthesia. Here is the trochlea. The trochlea is a pulley-shaped, or it is a medial pulley-shaped bony projection. It accommodates the trochlear notch of the ulna. You get, as you can see, it is like a pulley. So it's a medial pulley-shaped bony projection that accommodates the trochlear notch of the ulna. Superiorly to it is the radial fossa, is a small fossa. Now, this side is the capitulum. The capitulum is a lateral rounded convex bony projection is a lateral rounded convex bony projection that receives the head of the radius. Get. Superiorly to it is the coronoid fossa, is a small fossa. This is the lateral epicondyle. Here, the lateral epicondyle. The lateral epicondyle is smaller compared to the medial epicondyle. As you can see, it's smaller now. It's smaller. This one, like the lateral epicondyle is smaller compared to medial. Medial is bigger. Lateral is smaller. The anterior surface or the anterolateral surface of the lateral epicondyle provides site of attachment of the common extensor origin, which is for the extensor muscles in the posterior compartment of the forearm. Okay. Now, the posterior surface of the lateral epicondyle provides site of attachment of the anconus muscle, the anconus. Recall that this is the lateral supracondylar ridge. Now, on this region here, this is what we call the olecranon fossa. The olecranon fossa is a deep, shallowed fossa that is found on the posterior aspect of the distal end of the humerus, which is above the trochlea. As you can see, it's above the trochlea. This is the trochlea. This is the this is the olecranon fossa. Get. It receives or accommodates the olecranon process of the ulna when the elbow is extended. Get. So that is how it works. Because when the elbow is extended, it fits inside. It accommodates the olecranon process of the ulna. So that is why it's called the olecranon fossa. It is above the trochlea of the humerus. So that is how it works. Now, we have done justice to this bony structure. Recall that the fracture of the shaft of the humerus will cause lesion to the structures that passes on the radial groove on the upper part of the posterior surface of the humerus. You get. What are those structures? The radial nerve and the profundal brachial artery. Get. Now, fracture to the surgical neck of the humerus, surgical neck, will cause lesion to the structures that pass at that level, which is the axillary nerve and the anterior and posterior circumflex humeral vessel. Okay. If there is any fracture on the medial epicondyle, it will cause lesion to the ulnar nerve because the ulnar nerve is entrapped on the posterior surface of the medial epicondyle of the humerus. Okay. Now, fracture at the groove of or the ridge of the humerus, particularly the medial supracondylar ridge, it will lead to lesion to the brachial artery, which will cause Volkmann's ischemic contracture because the brachial artery passes downward medially towards this region. So if there's any fracture here, it will cause the lesion to the brachial artery, which will cause avascular necrosis to the blood, to the structures in the upper limb, because the brachial artery is the main, it is an arterial supply that supplies the structures in the upper limb, even forming or one of those participating artery that forms the anastomosis. You get. So that is how it does what it works. Recall that the medial nerve accompanies the brachial artery. So that fracture could also cause lesion to the medial nerve because the medial nerve accompanies the brachial artery. It crosses the brachial artery at the point of insertion of the coracle brachialis from the lateral side to the medial aspect of the arm. Here is the point of insertion of the coracle brachialis. The coracle brachialis is a landmark because it indicates plenty things. It indicates the site of the palpation of the brachial artery, where brachial artery can be felt or palpated. If there is any hemorrhage on the upper limb, maybe if there is a cut on the digit, if you want to stop the bleeding, you can come and press the brachial artery at this region. Then the bleeding can stop because the brachial artery is the main arterial stem that supplies the upper limb structure, apart from the axillary artery, which is the main arterial stem of the upper limb. Okay, we have discussed this structure. I've told you the clinical features associated with this region. Very, very important. Now, the last thing is the morphological neck, which is one of those neck of the humerus, although it occurs during development. So the morphological neck is between the diaphysis and the epiphysis, you get, during development of this bone. So it's a junction between the diaphysis and the epiphysis. And it is being replaced by an epiphyseal line in adult bone, you get. And is a true junction between the head and the shaft of the humerus during the development. So that is all about the humerus. The humerus has 8 centers of ossification, 8 centers of ossification. Bear it in mind, 8 centers of ossification. So that is all about it. Thank you so much for staying to the end of this class. I hope you understood it very, very well. Now, there is another thing I have to add. Stay tuned. In anatomical position of the humerus, note that the head of the humerus will always be directed medially, backward and upward. It must always be directed medially, backward and upward. That is an essential part. Now, the number 2 side of determination is the greater tubercle and the lesser tubercle and the intertubercular sulcus will face anteriorly. It will always be facing an anterior aspect of it. Why the olecranon fossa will always be facing posteriorly. So that is all about the anatomical side determination of the humerus. Thank you so much for staying to the end of this class. Endeavor to subscribe and anticipate for more videos like this.